Kasi ikaw po niya, ano? Ah,
Good evening.
Po.
Good evening.
sulod na.
Thank you, Doc May. I'm a former doctor to the barrio then, so and a former DOH and PhilHealth civil servant before I transitioned to development work or outside the government development work. So good evening. I am so pleased to join you tonight. And I apologize, no? I think I kept on moving itong session natin. It was initially Tuesday and now it's Thursday. Um, and I apologize for always changing the schedule. But I'm honestly grateful that you're still here and uh, still up and about kahit na 7 p.m. na. And I know na most of you just finished working. And I admire the energy, no, that you put into this. But anyway, just to give you a parang format lang of what's gonna happen the next 2 hours. The message that got to me is, or the request that reached me is that this is more or less a review session. I know that you have already or previously had modules and discussions and lessons, lectures on health financing given by Director Mamaril of DOH, HPDPB. And so, what I will be doing right now as I go into this session right now is I will just be reusing part of her lectures because I don't want to introduce any other, unfamiliar terminologies that might just confuse you all the more. We'll just stick to it since this is just a review session. It will be a short presentation because I would want to allot more time in questions, question and answer. Because siguro meron kayo mga as I was appraised, no, these are really you guys are the implementers and frontliners of UHC. So I'm sure in your everyday work in CHD, in the hospital, PIDOHO, you are already interfacing with a lot of health financing policy questions coming from, of course, yung mga reforms and policies coming from the national government, tas ibababa sa inyo. And then you are faced with a question na, what now? Okay? So, it's gonna be, an open session siguro on health financing after reviewing the terminologies. So, if that's okay with all of you, I will share now Dr. Mamaril's slides. Uh, can you see it? Can you see yung slides? Okay, okay, good. So I see thumbs up. Thank you. All right. So like I've mentioned on, this is I know there's a lot of PowerPoint and presentations na ginawa ni Director Mamariel, but I particularly chose this one as a jump off point in our discussion because um, this is what health financing or the theoretical meat of health financing its functions, and to be able to and she was actually able to clearly relate the theoretical functions of health financing with what's going on with our in actually in and place it in the Philippine context. Um, so this is just the outline of the presentation. Of course, we're going to go through, the usual. We will discuss the revenue raising functions of health financing, pooling, purchasing, and all the way to benefit design, and what are the governance in place for health financing functions, and of course the guiding principles, and lastly, and guiding principles in the health financing functions in support of UHC. Hold on na. Sorry. Sorry, narinig yung ano ko, nest, yung Viber. Sorry. Okay. So everybody is familiar with this framework. This is the from the National Health Financing Strategy, no, na WHO also came up with in 2017. It clearly lays out the functions, no. In fact, health financing is one of the tools, no, in reaching or building blocks in reaching UHC, and under it are its several functions to achieve the UHC objectives, and of course the um, coverage goals natin. So of course we have their raising revenue, pooling, purchasing, and benefit designs that will still affect, no, how our service that can affect how we deliver our services, and of course we see health financing as a tool to reach equity in resource distribution, and of course efficiency in how the way we use our funds, and also a way to make, spending on in health more transparent and accountable, and maybe traceable, no, to the population, and to specific outcomes. And of course, why we are all doing this, why are we talking about health financing, is because we want utilization to be relative to need, or reflect what's needed by the majority of our population, and not only majority but also our priority population. Um, we also aim for financial protection. We all heard the story of, people not being able to see doctors because of financial barrier, and of course we want to ensure that there will be quality when people, vulnerable population, our priority vulnerable population, when they access our health facilities, we want to make sure that we use financing as a carrot, no, uh, to make sure that there's quality in the services that they receive. So the first function of health financing is revenue raising. So we all know that we need to generate resources in order to finance all of the services under towards universal health coverage. And when we raise revenues, we want to move towards predominantly reliance on public sources. Why? Because unlike sa private, no, we can consolidate, mas malaki yung purchasing power kasi ng public sector compared sa private sector. And we make sure that the financial burden is shared fairly across society and ensure the stable and predictable funds to the health sector. So um, at least, so in this slide, Dr. Mamaril divided it into public and private revenue resources. So for public, we know that aside from loans and grants that are external revenues, no, that's being generated by the government. Yung loans yan, kasama dyan ADB. We just approved a loan for Build UHC, and of course we have grants coming from our overseas development partners such as USAID that gets pulled into the general coffers of the government. This is combined with the revenue taxes that they collect from direct and indirect taxes. So we are familiar with indirect, that's VAT, excise taxes. That also includes our sin taxes and the recent Train 2 law na tax na pinasa natin. For direct taxes, we pay, through income tax, we have payroll tax, and then, of course, our mandated prepayment, premium payments from PhilHealth, and of course, yung mga corporate taxes. And all of those things are pooled, or later na yung pooling, no? But in other words, this is how our government raises revenues to run the entire government. And the health sector only gets a portion of it. Not like dun sa syntax, no, na naka-earmark siya, but majority of, the loans, the grants, when they combine it in the general coffer, we only get a portion of it. And the portion, and who determines that portion? Well, it undergoes, the political process. And you are all very aware that there's an annual budget hearing starting from the lower house or the House of Representative all the way to the Senate before it gets approved by the president. So it's so in a sense, no, yan yung parang beverage model ng tax based, if you heard of it. So if tax based ang revenue sources mo, that's the entire process that you have to go through. And we have the household in the private naman na revenue sources, and this is more or less why we want to stay away from private, because it's so inefficient. It's usually through out of pocket. Majority is out of pocket payment, so we pay that through user fees or co-pays. Also, we try to pull or get prepayment services, what we call the voluntary health insurance, and those are the private health insurance, HMOs, MaxiCare. And in essence, no, out of pocket pa rin yun, because aside from our mandated premium payments from PhilHealth, we still opt to choose, to pay for those premiums, voluntary nga. But more or less, yung voluntary prepayment, if you're an employee, di ba, your employer actually pays a portion of it. Yung iba, kinakaltas sa sweldo. And as you know, this is the model on kung naalala nyo, that's Bismarck model, and that's from Germany, because that's where it started, no, na yung idea of, because for Germans at that time when they developed the health financing na Bismarck model, ang ultimate goal nila is to keep their employees healthy so that they can increase productivity. And so yun yung naging history nila on, that's why yun yung naging history nila on health insurance. So once we have raised revenues, or generate revenues, we now go into pooling. So pooling is basically the accumulation of prepaid health revenues on behalf of a population for eventual transfer to providers. We were not only also, so sa perspective ng insurance, no, and I guess pati na rin sa tax base, that the concept of pooling is not only pooling the funds, but you're also trying to pool the risk so that not one person will be the sole bearer of the financial burden he or she has to take. So for example, sa insurance concept, no, when I contribute, so let's say you have a pool of people, a 10 or a group of 10 people contributing to the same fund. You don't know who will get sick in that 10 people, no. But you're just saying na I will just, constantly um contribute to that fund, so that if any moment or any day or in the year that I will get sick, I will be able to get something from that pool of fund to pay for my sickness. So I will not bear the true cost of the expenses right then and there. It was already, parang nagkaroon ka na ng smoothening of your risk, or smoothening ng risk mo. You spread the risk already in terms of premium payments. So pooling is central to the achievement of equity in resource distribution and equity in service use and financial protection. And why is that so? Because pooling is also related or linked to resource allocation. So in terms of pooling in the government, in the public sector, no, you reallocate based on the demographic profile risks, no, na isang population. um, and and in a sense, no, you promote equity in that sense, na sa you give more to the less, and or you give priority to those who need it most. So there are mechanisms, no, and there are multiple pooling entities in the current health system of the Philippines. So as you can see, it's again separated by public and private. So in public, there's two main, or well, not actually two main, no. There are multiple pools in the currently in the health system. There's a pool of fund within the Department of Health. They get it uh, from an earmarked, or what they call allotment, no, from the government allocation. LGUs get their era pa ba yung tawag? Alam ko binago na eh, um, but in other words, no, may sub-allotment sila, or allotment from the national government. NTA, there you go. National Tax Allocation. Tama ba? So LGUs get a part of it, no? But the NTA that's being downloaded to them is not earmarked for health. So ibang labanan na naman yan pagdating sa LGUs. So and I'm sure our partners in our colleagues and friends in the LGUs na mga uh, MHOs very is very familiar with the political process of fighting for funding for health once na bumaba yung NTA. We also sub a lot sa other NGAs, no? And most of them based on, yeah, so dun na muna tayo sa three pools na yan. And then PhilHealth also has their own pooling mechanism. So PhilHealth, based on the law, can uh ano to can charge premium payments, di ba? Based on the capacity to pay of the direct contributors. And if you remember the table of premium rates, it's progressive yung um pagkaka-compute nila for the premium rates, meaning they get more from those who earn more, 'di ba? And then so ganun yung pagkaka-compute nila sa premium rates natin, for at least for direct contributors. Now for indirect contributors, the premiums are being paid for by your through government subsidies. So doon nagagaling yung earmarked funds of sin tax. They used to pay that for UHC coverage, premium coverage. Um, and also for to cover also your senior citizen PWDs and all other government mandated na subsidies. And everything and those two revenue sources ng PhilHealth gets pulled within PhilHealth, and that's what they use to pay for individual based health services. Yung all others, DOH, LGUs, and other NGAs, they use that to pay for population based health services. And that's according to our law, UHC law. Now, when we look at private naman, um, you have both voluntary prepayment, and that's what we've been talking about, the private health insurance. You have HMOs, your private health insurance companies, which are also used to pay for individual based health services. And of course, if you're going to look at our current health expenditure, we see majority of our health spending is still out of pocket, and we usually use our own money to pay for other services that's not covered by PhilHealth or any other DOH programs, and or user fees. Ah, Number one driver of out of pocket in the country is actually medicines. So now once we pull those funds, so as you can see, no, ang dami nating pooling. We have multiple pools our health system. PhilHealth has its own pool, DOH. Before the UHC law, there's no clear demarcation between what DOH should pay for, what should LGUs pay for, what PhilHealth should pay for. And more often than not, they are paying for the same set of services, unfortunately. But with the UHC law, we said that, DOH and LGUs focus on population-based health services. That includes health promotion, those that have population impact on the population, programs that have impact on the population. And then we say PhilHealth just focus on individual based health services. So that's how they sort of address you multiple pooling with and overlaps in health financing. Okay, so now we go to purchasing. Now, purchasing refers to the allocation of pooled funds to providers that deliver healthcare goods and services. And one of the um, purchasing method siguro na or approach that you've been hearing is strategic purchasing. And strategic purchasing, it basically says that, we allocate funds based on priorities. Uh, ng stated priorities based on the health needs assessment and performance through payment methods and payment rates that create incentives for providers to manage their expenditures, make efficient use of their resources, focus on quality or quality performance metrics. So, in other words, ang strategic purchasing is basically deals with the questions ng um, what to buy, where to buy it, and how to buy it. So, what to buy? Of course, ano ba yung priority natin na i-address as a health system? What are the services that will address the burden of disease? That can be one prioritization tool based on the burden of disease. Next question is where to buy? Of course, you're gonna look now on the supply side, who will be the available um, providers of that services. And then lastly, how to buy it. So, dun na papasok yung provider payment mechanism natin. Provider payment mechanism involves yung napag-usapan natin sa PhilHealth. We have, of course, case-based rate or yung popular na ACR. There's also DRG, but other na non-health insurance method of payment mechanism is fee for service. meaning kung ano yung line by line budget, line by line na binigay na service sa isang pasyente. There's an attached price to it, and then they just total it, and you pay for it. But PhilHealth already stayed away from that because they cannot control the expenses, because in other words, no, everything under the sun na pwedeng i-prescribe ng provider, pwedeng bayaran ng PhilHealth. But we know that, we need to also be mindful on how we will be spending our funds efficiently, especially sa ating national health insurance. So those are the three things that, strategic purchasing aims to answer: what to buy, where to buy, and how to buy. So strategic purchasing is critical basically to enhance efficiency, equity in access, quality, as well as financial protection. So these are the 10 leading sources of inefficiency in terms of health financing. So of course, yung medicines, if we don't use generics, then so remember I told you that the main driver of out of pocket right now in the country is really medicines. So if there are plethora of branded medicines na we know that they're more expensive than their generic counterparts, then that drives our out of pocket and the overall health expenditure, health system, current health expenditure. So of course, if there's inappropriate, or there are other indicators in medicine news, no, na hindi directly related to price, but it actually on provider and patient behavior, and that's if you inappropriately use your medication, like for example, hindi naman kailangan ng antibiotics for a viral flu, then that's a wastage pa din. In If you're gonna look at it at a macro perspective, that's a wastage in the health system, because you are not supposed to be utilizing something that's not appropriate at a given point of time. And of course, use of substandard and counterfeit medicines, which we all know na it eats up much of our budget, and then it doesn't lead us to the goal or outcome that we want to achieve. Services and products that are oversupply and overuse. Again, no, it begs the question of efficiency. Interventions, inefficient mix, or inappropriate level of strategies, especially I think in this example, no, it's not only on the money, but if you monetize effort and time in strategies that will not lead you to the right outputs or outcomes that you want to achieve, no, then that's a wastage in the whole health system. In terms of services, of course, we know that's inefficient if there's a lot of medical errors, or if you provide suboptimal quality of care, and inappropriate hospital size, low use of infrastructure. So yung mga if we invest in hospital, if we invest in an infrastructure and we are unable to even equip it, it's a white elephant. So that's still inefficiency in our health system. Inappropriate hospital admissions and length of stay. We are all familiar of that. Of course, if we also have inappropriate or costly staff mix, and unmotivated workers, and that will all lead to wastage in our health resources. Of course, corruption and fraud. So how are we going to be able to address all these inefficiencies through our purchasing structure and provider payment mechanism? So we have so in terms of provider payment mechanism, no, we have hello, may question. Okay, sorry. So parang medyo busy tong slide na to, but i- there's one slide na I use in my some of my lectures, and it's the emphasis on you could actually use your provider payment mechanism to sort of mold the system or align the objectives of both your provider, which are your doctors, and your patients. So much of the inefficiencies here in our ito yung leading sources of inefficiency natin, no, it's sometimes provider driven and sometimes patient driven. So there's a tool or there's a power in the provider payment mechanism that if you get it right, if you are able to design your payment provider mechanism well, then you will be able to align the objectives of the payer, which is the national health insurance, the provider, and the patient. So because we know, no, may iba't iba silang objectives. Your patient, ang objective niya is for them to get well, right? That's why they want, quality services. They want appropriate medications for them and diagnostics. Um, and the provider, of course, ang objective nila, gusto din naman nila maging magbigay ng appropriate or in quality service, but also at the same time providers also want some revenues, right? They want to earn or to be able to get an income out of the services that they are paying. And now papasok si payer, which is your national health insurance, and making sure that all the objectives so meron siyang sariling objective yung si insurer mo or yung payer mo. And that's to make sure that I pay the provider and I made him do the services that I want him to do, which is basically providing also quality, but ensuring that the cost is lower and I'm paying for the right services, hindi over yung services na binibigay ni provider. And so, uh, like I've said, I kept on saying, no, the way you structure the provider payment mechanism can actually align all those objectives. And so we now go to how we can structure, no, our purchasing or provider payment mechanism. So in in essence, what we advocate really is a single national payer who will be able to consolidate all the funds so that we can pull the risk and pull the funds, and at the same time can be a purchaser on behalf of the majority of, in this case, the Filipinos, because it consolidates it, because when you consolidate the funds, your purchasing power becomes stronger. Not like if you have multiple pool of funds, and then iba-iba yung you know sizes nung pool ng funds mo, then nagiging weak yung purchasing power mo. So that's why, in the UHC law, we advocate na we should have a stronger PhilHealth to be able to do a strategic purchasing on behalf of the Filipinos. And now PhilHealth is undergoing, restructuring in their provider payment mechanism. ACR, or all case rate, is actually a retrospective payment, reimbursement kasi siya. So we say that, providers, provide nyo muna, or hospitals, doctors, you provide the services first, and then you reimburse it to us. In the UHC law, we moved away from that. We will now say, we will do, so let's go muna dun sa current, no, sa retrospective. Now we have fee for service and case-based reimbursement. That's our ACR. What's the problem that you create in terms of retrospective? Number one is you can't control the prices. You can't control the cost. So for fee for service, yun yung glaring doon, di ba? You are basically giving provider a blank check na okay, just list down everything that's in there, and then we'll pay for it. And administratively, that's very burdensome also for PhilHealth because they would have to audit each and every services that's provided to make sure na yun talaga yung appropriate na services for that case. Um, so so now they're moving away from that and doing prospective payments. Now for prospective payments, we have two types, line item budget, global budget, and capitation. Line item budget is what we usually do for national government agency, but the restriction there is that, well, you're constrained with what you wrote like a year ago. Diba? And sometimes we get innovative. We use very vague line, terms just to be able to have that flexibility. But if you want to use that funds for another purpose, you have to go through, different bureaucratic processes, and that's not very applicable for health insurance na very dynamic yung needs ng population. So what we are now looking at is doing a global budget or capitation. So for global budget, it's basically um, you'll look at the historical expenditure of the hospital, plus taking into account the epidemiologic profile siguro of the population, and then you multiply it with the cost of providing the services, so nandun yung benefit design, and then that's the total amount that you will be giving to the hospital in advance, because you agreed that okay, based on my historical data, this is the number of appendicitis patients that I treat, na may surgical services or needs then. And you now download it in advance to the hospital. When you download it in advance sa hospital, you also transfer the burden of, budgeting and making sure na efficient yung um, pagkakaspend mo, because that's your entire budget for the year. Um, and with the assumption that it will cover everything, not only the cost of services, but also the cost of operating uh, or running the hospital or the health facility. So, in essence, no, you pass on the burden of budgeting and making sure efficiently ang pagkakaspend nila to the provider. Um, so that's one advantage of global budget. Capitation, on the other hand, is as they say, no, capita per capita, and we usually do that for and this is what we have been doing actually for our primary care services. Consulta package, right? From PCB and Consulta. So we computed yung what will be so it's similar with global budget, but this is per capita, which means per individual. Before, per family ang computation natin ng capitation, but now we're looking at per individual na. So what is the cost of healthcare, let's say, of an individual for a year? And that's what we usually use this type of provider payment mechanism for primary care. There are other mixed methods. So now we're looking at, combining not just capitation for primary care, but some sort of mixed methods or blended payment that includes capitation, pay per performance, and a mix of fee for service or case based reimbursement. We are also, PhilHealth is also now looking into combining global budget with DRG, or if that's not gonna happen, then we're gonna do ACR plus global budget. In other meaning, kung ano yung rate under the current scheme, we'll just multiply it with the historical trends of the hospital or the epidemiologic profile of the catchment area. And that's gonna be the global budget. So parang ganon. Um, so as you can see here, we can be very innovative, and we can use any provider payment mechanism, let's say to pay for primary care units, for individual practitioners, outpatient specialist services, and inpatient. In other words, there's no um, one single truth when it comes to how you pay your providers. It's really it will have to link back again dun sa ano ba yung equity, efficiency goals mo as a sector. So if you want cost containment, then you can go for global budget because it's very strict, in cost control measures. So it really depends, no, on how ano yung objective mo when it comes to achieve when it comes to provider payment mechanism. Okay. So we now go to the last function of um what do you call health financing, sorry. And that's on benefit design. So basically, no, ito yung nagdedetermine on, well, benefit design is a set of publicly funded entitlements for a defined population group. So, ano yung benefit package, ano yung entitlements nila. And also, you need to put to put conditions or rules on who can access at what time and ano yung entitlements nila. So, is it so ano yung obligations, no, na you have to meet before you can access these entitlements, and how it's gonna be rationed or rationed to ano yung rationing nung entitlements na yon. So I guess yun yung okay. So we go to governance of the health financing function. So we have accountability, participation, predictability, and transparency. Um, we need, in other words, though, these are the things that we need to advocate when we look into when we analyze or assess each and every health financing functions. We make sure that all policies governing those functions would be able to we can be able to account for the spending, no, uh, of of let's say for global budget. So even for capitation, even if in advance you download the money already, but it doesn't mean it stops there. But there should be monitoring and utilization report that's still gonna have that you're still gonna put in place to make sure that we still account for how hospitals or health providers use those funds. We make sure that there's participation when it comes to benefit design, and even the reallocation mechanism after pooling, who gets what. And of course, the strategic purchasing. We need participation of the vulnerable population to be able to be guided on what to buy, and how to buy it. And of course, predictability of, at the end of the day, we need to be predictable. Kasi yung whole business model ng health insurance, it relies on trust. So if you're not going to be able to predict that, and that the health insurance will be able to pay for your services after you get hospitalized, then you lose the trust in the institution. And of course, we need to demand for transparency. So just few guiding principles for health, and health financing reforms in support of UHC. So we now move like I've mentioned, we move towards predominant reliance on public funding sources, because there's a major advantage when it comes to, if we have a single purchaser who is be able to consolidate all the funds and pull the risks and just leverage on the purchasing power, of a single purchaser. And we reduce fragmentation on how funds are pulled or mitigating the consequences. So basically yung fragmentation na yan is being answered now by clear demarcation of roles. We say, PhilHealth will be individual based, and then DOH and LGs will be population based. And we move towards more strategic purchasing of health services, linking provider payments to data on their performance and to health needs of the population they serve. And lastly, aligning coverage policies explicitly with policy objectives. So I guess this is the last slide of Dr. Mamaril. I took an hour. Sorry, mahaba pa rin pala. But I'll stop there. And if there's any clarification or question, please feel free to raise your hand. Any question? Wait lang ah. Titigil ko muna yung video ko. Paano ba? Kasi iinom ako. Hindi glamorous ang pag-inom ko. Wait. Uy, Ken, you're here. See you. Si Ken dating 4B yan eh. Kasama ko sa 4B. Tama ba? Ken, is that you?
Yes, Dra. Hello, Dra. Good evening po.
Hello.
Hi, Dra. Good evening po.
Hello. Mga 4B ba to?
Hindi po. Dra, may clarification lang po ako.
Sige po.
Pagdating po dun sa pooling na function natin, pwede po ba yung mga private donors na, for example, aside from the other donor, yung mga pinagkukunan natin ng resources, pwede bang yung private donors maglagay din ng fund doon for pooling?
I'm trying to remember, no, kasi sa SHF, yun yung pooling mechanism natin at subnational. Ang SHF kasi, it was the objective why we have SHF right now in the UHC law is to answer etong fragmented and multiple sources of funding natin for health. We want to be able to consolidate lahat yan because, di ba, may bumababa from DOH, may bumababa may meron nilalabas sa LGUs, and sometimes hindi nakikita yan, yung mga multiple sources of funding na yan. So we say na we'll just put up a fund so that everyone can pull in there. And I think in one of the hindi ko alam kung IRR ba yan, hindi ko kabisado yan. Pero I saw a presentation from DOH in terms of primary care funding that they are also, so aside from DOH grants, I think ODA, development assistance, overseas development assistance, like I guess USAID, can still also pull dun sa SHF. So if you have a provision in your board resolution siguro, I'm talking about subnational, board provincial resolution or LGU resolution, that you will allow private donors to pull in the SHF. I don't think there's anything that precludes you to do that. It's just a matter of laying it out in the policy. and making sure no na nakasulat talaga siya kasi otherwise baka makowa kayo.
Yes, doktora. Oo. Kasi gusto kong tingnan talaga yung mga private donors din if ever magkaroon sa localities natin sa namin about dun din sa pooling of funds. So tama po na we need the policy for that and siguro MOA talaga.
You can actually look how they kasi meron tayong sample niyan, no? You could actually look how they phrased yung kung ano yung pwedeng kung sino pwedeng mag-pull ng funds sa, have you heard of the Cancer Supportive Medicine, Cancer Supportive and Palliative Medicine Access Program? So, if you're going to look at the NICA law, binigyan niya ng provision doon or legal hindi mandate para inallow niya legally na mag-raise ng funds for CSP map and of course get funding from donors. So if you can, sort of use that as a template on how to word it for your own board resolution, you'll have a protection na when kunyari may darating na donor and wants to pull in sa SHF. Just a suggestion.
Okay, thank you, Dra. Dra, another clarification about the MAF, yung medical assistance for indigent patients na pera ng mga politicians, saan po siya bali maikakategorize dun sa financing function ng financing Dra?
So, MAP is very innovative. Financing, yun yung, I think, best way to describe it, no? It's, if you're going to look at the history kasi ng MAIP, it was conceptualized because it was born out of the, I guess, yung hindi pa kasi ma-meet ng PhilHealth yung target niya, which is universal coverage. And that's why, for those are who hindi pa rin kasi enough yung coverage ng PhilHealth, right? So that's why you have other medicine access program or pools who try to augment itong PhilHealth. So it's still, it's under DOH, which is now based sa batas sa population, should be paying for population, but MAIP is being used for individual-based health services. So it's not a health insurance. It's, paano ba natin siya i-describe dito? It's basically an earmarked funding for specific individual based health service. Pero if it's for health financing, no, it doesn't also follow yung principles niya,
Yes.
yung governance
Kasi,
that we
opo,
want
kasi
to
individual siya. Hindi siya yung population-based yung ginagastusan.
oo. So it's a very innovative health financing strategy, and it's not unique sa Philippines. UK actually faced a similar uh, funding or innovative financing mechanism. Because UK, no, sa kanila galing yung HTA na yan yun nice. So ang gobyerno nila, so tax base sila, so everything is publicly funded. Konti lang yung percentage ng private sector nila. So lahat ng hospitals doon are owned by the government. And it's tax funded. But they put in place a safeguard, yung NICE or yung HTA, na they will heed dun sa recommendations ng HTA on what they should be paying for. And the process of HTA doon is medyo stringent and matagal. And most of the time, hindi na a-approve yung mga innovative cancer medicines. So ang sabi ng Parliament ng UK, will just create a separate pool of funds for cancer medicine because ang tagal nitong NICE magsabi, and yet may clamor from the population na i-cover yung high cost innovative cancer medicine. So they put up a fund. So it's similar with MAI, pero hindi siya uh, budget ng congressman. Hindi siya attached to one personality. It's, a national pool fund pa din. But more or less, ganun din yung intent, di ba? Yung objective. It's because yung existing structure mo is not meeting the needs of the population. So, ang naging discard is just create a separate pool of funds that will hopefully augment yung kakulangan ng existing system. And so, you can put it as innovative financing, a band-aid measure, but ultimately the question now is it efficient? How are we going to monitor the utilization? And what kind of provider behavior
Yes.
are we incubating, in other words, or
Yes. oo.
encouraging?
Okay, thank you, Dra.
Sorry, mahabang sagot sa ano.
Yun na po yun, ma'am, yung tinanong ko na po kay Doktora. Okay na po. Ako po yun na nagtanong na.
Ako yung magtatanong, ano yung burning question niya sa subnational when it comes to health financing? Ano yung parang hindi nyo mag-grasp na national policy reforms na ibababa sa inyo na kailangan yung i-implement? Anong aspeto ng health financing are you struggling as a frontliner implementors? Ayan, kasi ayaw niyo magtanong. Ako tuloy nagtanong. Yes, Melanie.
Good evening po, Doc. One burning question and a struggling ngayon ng local government units is the implementation of the devolution transition plan.
Pero ano na yan,
Where,
di ba? Na-halt na siya. Hindi
Opo.
na siya. Oo.
Yeah, but they are still forced ang LGUs to hire the manpower, yung mga na-devolved na like hire a disease surveillance officer, a health promotion officer. Since na-put on hold po ang implementation, when do we expect na ipupush ulit ang implementation nito since gumawa sila ng mga plano but the financing did not come, so their national tax allocation were low for last year 2023 and this year also.
Yeah.
Kailan po kaya ang expected na the NTA will be increased so that the LGUs will be able to implement the devolved programs po? Thank you.
Yeah. Unfortunately, hindi ko rin siya masasagot. Kasi kami rin naghihintay ko kailan siya. Oo. But it really did cause a problem, no? Sa LGUs. Sige. Melanie, tiga saan ka?
I'm from Cordillera po, Benguet Province.
Oo. Region Office, DOH?
Pidoho po, Provincial DOH Office.
Oo. Yeah.
Yeah, it's a question kasi na we cannot answer sa aming mga local chief executives.
Yeah. Talagang funding, no? Yeah. And unfortunately, I don't have an answer for that as well. Sorry.
Thank you po.
But we can provide technical assistance once na meron nandiyan na yun on HRH, yung ATV.
Thank you po. Yes po.
Ito yung pinakamaliit na NTA since ito po ay 2 last preceding years. So, pababa ng pababa. So in other words, with all these mandates on UHC reforms and investments, no, lumiliit naman ang um, tax allocation. So it has a detrimental or negative impact din on how, MHOs and even health champions sa ground para mag-request na increased funding for health. Is that right? Kasi mas lumiit ang mas naging scarce ang resources, tas mas tumaas ang competition for those very scarce resources. Yeah. That's so yun. Any any other question? Wala kayong burning question, other burning question? Brian, I see your hands.
Yes po. Doktor, correct me po if I'm wrong kasi yung understanding ko po sa pooling of funds sa Special Health Fund, di po ba yun yung pooled funds under ng Universal Healthcare?
Mm-hmm.
So parang ang pagkatanda ko po doon, yung makaka-access lang ng Special Health Fund na yun is yung mag-integrate doon sa healthcare providers network na local government unit.
Yep.
So papaano po yung local government unit na hindi mag-integrate dun sa healthcare provider network? Papaano po yung health financing nila?
Yeah.
Especially sa PhilHealth. Thank you po.
Nako. So we're providing technical assistance sa DLHSD and DOH on just helping them figure out SHF. There are a lot of uncertainties pa when it comes to ano magiging itsura na SHF, no? And that question that actually has been, a recurring question. And so I really don't have an answer to that because, yung prerequisite of integrating is already quite a complex task. And then, prerequisite pa siya to another complex task, which is your SHF. So, instead of answering that directly, no, I'll just go to the question. I'll just go back to the objective, bakit tayo may SHF. So aside from pooling, really the intent of SHF is to ensure that the income of the health system will remain in the health system. So what am I saying is that di ba in our previous context before UHC law, when a hospital, let's say ang LGU hospital, nagkaroon siya ng income coming from PhilHealth reimbursements. But let's put it as perspective na income pa rin naman ang tingin sa PhilHealth reimbursement. It goes to so let's say ang owner ng hospital is LGU. It goes to the LGU. Now, kung may trust fund si LGU for PhilHealth reimbursement, then that's well and good. But then, iba na naman din yung labanan na discussion na paano kung wala? Then it gets mixed up with the all other income revenues na LGU. And then, we don't know anymore how it's going to return to the health system. So, yung importance ng SHF is really to make sure that may income retention yung health system natin. That it doesn't go anywhere else. It doesn't go to any other sector. But the money na generate natin, the resources that na-generate natin through PhilHealth will still go back to the health system. And and it's a concept now na we're trying to also, aside from pooling, no, that's the concept that we want to impart on in terms of how you see SHF. um, but it now, however, no, with all these integration and all that, we need, and that's the challenge now sa DOH and PhilHealth, na how are we going to recalibrate eto mga prerequisites natin, given the context nga na, hindi lahat ay gustong mag-integrate into network. And so, ano ang gagawin natin? You're right, eh. Anong gagawin natin doon? Ilalaglag na lang ba natin yung access natin? Or we'll just completely ignore them? Or, and these are the details uh, in the implementation that needs to be ironed out. But believe me, Brian, it's part of the conversation that's in the table right now. Are we still going to use integration as a prerequisite? Kasi in honest, and this is not my hat as an ADP person, no. This is my hat in implementation. So I would just like to caution, do not quote the organization when I say this. Ano? But, baka naman they can explore some other way na we don't have to, and use SHF actually as an integration tool, to entice people to, just thinking it the other way around. Use SHF as a carrot to encourage, providers to integrate, rather than the other way around, by saying na integrate first before mo ma-access yung SHF. Baka mas may diplomasyang way that we need to explore as a health, health policy people. Yun lang yung sagot ko. Sorry, kasi it's so difficult to answer, questions, lalo na, yun nga, I need to, ano na, I'm not from DOH. Yes, Melanie. And then si Genesis.
Sorry po, makulit. Sundan ko po yung question kanina on SHF. Kasi one of the issues sa aming local government units, meron yung joint memorandum circular of DOH, DBM, and DILG on SHF. And my statement doon that LGUs participating shall appropriate mandatory counterpart funding to finance the health program. So parang we still cannot explain why the LGU will contribute or give its mandatory contribution for its plan. So bakit pa daw magko-contribute kung yung plano din lang nila ang implement nila, i-fund na lang nila on their own yung ganun, Doc. Can you expand more on how this pooling with the mandatory counterpart funding will be? Thank you.
Well, going back tayo to what it's trying to address, no? Yun nga sa SHF is yung fragmented pools, different pools of funds, and we want also income retention. So sa health system, and that's why you have SHF. But that's an AO. People, and I'm going to say this, no, na parang the central office, I think, needs to listen to you more, because kayo yung humaharap sa LGUs, and their misgivings on that provision. In all honesty, that can be revised, because that's an AO. It's not mahirap kapag nasa batas, di ba? But if you're gonna look at the law or even the IRR, it's not there. So if it's something that you need to raise during plenary discussions when you have the opportunity, kasi it can still may habol pa naman. It's not the end of the world.
Thank you po.
Siguro si Genesis.
Evening po, Doc, at saka sa mga classmates ko. So, parang sa January 16, kung multiple choice, matching type, or narrative man yung type of question, for sure, sa presentation nyo, Doc, at saka explanation, I think they will have this good answers kasi will explain yung
naman.
presentation. So yung tanong ko po, Doc, is about the universal healthcare.
Okay.
This is I am not well versed, Doc. Just trying to be one here. I'm not trying to be intellect here, but based on my how I digest and connect the keys that I've heard. So the UHC is more or on the prevention side, wherein kung titignan natin sa kanang kumbaga yung consequence niya mas tawag doon, maliit yung budget na mailalaan sa primary care, unlike sa curative part na masyadong mahal. So for that, Doc, health is kumbaga in science, evolutionary, nagbabago. Health has many determinants wherein masasabi natin na yung linear na ginagawa natin, yung structured or mga generic or template na present, mostly narinig namin at saka na-reinforce you today is that kumbaga sa primary care wherein we are delivering services, yung binibigay sa amin, pero our environment or our market are distracting. Examples are the food, for example, that makes the people unhealthy. So is healthcare financing mas this mga kaning trajectory, kumbaga, how they finance this market strategies wherein they are also bombarding, they are also contaminating our kumbaga yung services natin, because yun yung contaminant kung anong rason na hindi natin na-achieve yung to taper down or narrow down yung non-communicable diseases. It's because there's still there are still mga contaminants, in my own term, like the industry are still selling cigarettes, and then the foods are not healthy and mostly processed, that the lifestyle of the people are very talaga, Doc, promote shortening your longevity. So yun yung kwan ko, Doc, yun yung integration ko, or ano ba yung baga ang DOH ba ay nag-a-upgrade din sa kanilang mga way of dealing with the people, how to address, because our tawag doon, yung nature is umiiba. Kumbaga, Doc, iba naman yung atake or strategies na gawin natin, because we are kumbaga, the paradox of our services. Nagbibigay tayo ng services, meron ding mga externalities na nagko-contradict din sa ating services. So, part doon yung determinants of health, kasi if we do not address some other issues, yung health problem din ay mag-prevail. So, Doc, sorry for some uh, dragging ideas, but yung sa UHC and then sa healthcare financing, so may part ba na breakthrough kumbaga sa atin na magiging ilatag din sa local government unit or sa mga implementors to why try this? Kasi babalik-balikin yung problema, baka ito yung solusyon. Thank you po, Doc.
So, Janice, that's a very good question, no? Kasi we've been talking health financing on the perspective of PhilHealth lang. In fact, the entire presentation that I have deals on, how the mechanism of how social health insurance works and how it actually can be used to align objectives of both patients, providers, and the payers. But the kulang nga din ng konteksto on how we can use health financing to um, sort of address yung preventive measures or preventive care ng health system. But dun sa UHC law natin, actually meron yan health financing na provision especially on aside from answering yung fragmented or no clear demarcation of who pays for what. Diba? Part yan the question of health financing who pays for what. And there we say na for population-based, which includes promotive health, it's DOH. And in fact, also part of the UHC law is the institution of a health promotion bureau within the Department of Health, which is now in charge of making sure na healthy living, healthy communities, healthy school, healthy learning institutions, yung mga ganon. And they're also into understanding what are the nudges that can alter the behavior of a community, of an individual, so that they can make the right healthy choices. And sometimes, ang isa sa mga, I think, tools nila is to provide incentives, right? We know, and you're right, it's beyond the health sector, it's actually addressing social determinants of health. So you incentivize the people who are governing the social determinants of health at the subnational, and you still have the LGUs to do that. And so they provide grants, performance incentives, and that's still a health financing tool, in my point, because you use, the financing, the grants, block grants as a carrot to make them do or to align, to make sure that you align, maia-align mo yung objectives mo or share mo yung objectives mo sa kanila, and you actually make them do something that will lead you to the objectives that or the outcome that you want to achieve. So it's just one of the things na we can do to nudge the LGUs or even individuals to in terms of promotive care. I remember Singapore has this program wherein if parang app that can track how many steps that they can make in a day. And if let's say na-reach nila yung 10,000 steps or some number of steps, then they can use that to get some grocery items. So that's incentive. It's still, financing in a sense na you provide nudges through financing schemes. So those are the innovative practices, no, na hindi lang natin siya nilalagay as, hindi lang nale-lecture unfortunately as health financing, but in a way those are small steps or good examples on nudges. I hope I answered your question. Rona. Ay, sorry, si Riza pala muna and then Rona.
Hello po, good evening po sa lahat. Bali, pasusundan ko lang po yung idea ni Genesis, na sinabi niya na mahirap nga kasi nga mahirap ang health financing kasi nga nag-e-evolve siya. Lagi-lagi siyang nagkakaroon ng pagbabago, no? Kaya po I think doon po papasok if I may, doon na po pumapasok ngayon yung plano natin sa local government unit natin. Kung ito ba ay short term, medium term or long term. Kasi yung pong mga pagbabago na nakikita natin in 1 to 3 years time, madali po siyang mabago dahil nakikita natin situational analysis ng ating mga lugar, no? Yung ating mga local government units, kung ano ang health situation niya. So doon natin mababago kung ano yung mga plano natin para sa mga susunod na taon. So doon po natin ma-allocate yung budget natin, and then considering din nga po yung diniscuss natin kanina regarding po yung mga programs na made-devolve, darating din po ang time talaga na magkakaroon talaga ng devolution ng mga programs from the national government. Ngayon ang magiging problema namin do sa local government unit, do sa local government is paano namin ma-allocate kung ang situation ng aming lugar is ganito, paano namin ma-allocate kung devolved na yung program. Yan po yung malaking question din kanina ni Melay, no? Kung kailan, kung handa ba tayo? Dahilan naman siguro na ang science is always evolving. Baka pagka dumating tayo sa panahon na talagang magkakaroon na talaga ng devolution, baka by that time meron na po tayong mga sagot sa mga questions na yun. So, yun lang po yung mai-share kong idea. Maraming salamat po. Good evening po.
Thank you, Riza. Actually, nangyari na, Riza, ang devolution. Matagal na natin siyang ina-address yung naging problema na kinos ng revolution, which is really yung na-fragment yung health system natin in terms of service delivery and health financing. And one of the means to address it is actually the UHC law. That's why the UHC law was heavy on integration and pooling of funds and making sure that we have PhilHealth as a strategic purchaser because dahil nga hindi natin we are still facing yung fragmentation, and it brought us inequities, inefficiencies in the health system. But of course with the UHC law, nag-create din siya ng implementation problems sa atin. And that's what we're all trying to figure out now. But I think at the end we're slowly moving in the right direction, right? Kasi kung wala yung UHC law, there's a lot of reforms na walang legal basis, and UHC the law actually gave us the legal mandate and not the flexibility, the legal basis talaga to to do the reforms. Excuse me. Yeah. Rona?
Good evening, Doc. Good evening, classmates. Rejoinder po doon sa question ni Mamela, di ba sabi po na meron tayong AO na mandatory yung contribution ng LGU doon sa pool of funds. Di ba pag na sila UHC, yung pool, paano po yung allocation back to LGU nung special health fund? And then yung sa konsulta package, yun bang mga reimbursement nung per LGU? Kasi di ba unique po yung LGUs natin, merong malaki, merong maliit, merong masisipag, at merong medyo chill lang. So paano po yung Doc, yung allocation ng funds ng special health funds dun sa mga LGUs? And how about dun, di ba, merong halimbawa walang gustong mag-integrate ng na LGU dun sa province. Kasi maliit na LGU, merong malaki. Yun po, Doc. Thank you.
Yeah. Rona, alam mo, natutuwa ako kasi that's really not kasi in theoretical discussion, no, academic discussion, then you are able to grasp yung health financing concepts already. Na you're right, no, pag pinul yan, paano yung reallocation and redistribution mechanism from that pool funds. And May, di ba, nakakatawa kasi they're already using those terms. On the other hand, that's a policy question that we all need to answer as well. And, kasi at this point, unfortunately, no, kulang talaga din yung guidance. That's why we are all asking on the reallocation mechanism. But in theoretical terms, allocation is actually based on some sort of risk adjustments. So, ito lang yung mga tips lang on, let's say, we'll discuss allocation mechanism, no? Some sort of, yung iba, they employ, how they figure out how much should be reallocated is based on some risk adjustments. So, risk adjustments can depend on, the demographic profile of your population or the communities or your constituents. That includes, the aging population ba to? Or let's say mas marami bang mas bata, or nasa reproductive stage ba yung population, because ultimately, no, depende sa demographic mo, mag-change yung health needs nila. So that's one risk adjustment that you need to make when you think of allocation. The second one is based on the epidemiologic profile or the burden of disease prevalent in the community. So you can have ano ba yung prevailing? Is it more on infectious TB ba to? And then, or non-communicable. If there's a range of diseases prevailing, then you prioritize. So those are the types, no, na you can do when it comes to determining how you are going to reallocate. It's not simple. Now, 1:1. It needs some participatory, ito na yung governance structure ng health financing. It needs some participatory, and which means a lot of consultation on what you will be prioritizing at the end of the day. So based on the demographic and epidemiologic profile, just to name a few, no. But that's how I'm going to answer your question. Now, in the absence of, let's say, guidance, and this is the premise, no. I'm saying that in the absence of, a guidance from the national government. So that's the theoretical answer to that. But of course, sa implementation, meron ka din mga innovative practices. You still need to think of ano pa ba yung efficient way of allocating it. Are you just going to, because meron din tayong iniisip, di ba, na parang if we pull funds at the provincial level, paano din yung procurement niyan ng medicines? magpo-pull din ba tayo ng procurement natin at the provinces? Will the provinces now purchase on behalf of all the health facilities in and municipalities? Is that even possible? Then, mag-iiba yung reallocation mo because, you're going to keep some of the SHF funds so that you can purchase on behalf of the municipio. And there's an advantage to it if you're going to see it in a, financial management perspective because kapag nakapag aggregate ka ng orders, then lumalakas yung purchasing power mo because you are now going to be able to negotiate based on volume, right? And as we know, pag napakyaw mo yan, mas pwede din bumaba yung cost of medicines rather than, tingi-tingi ang order ng LGUs. So, those are, some innovative perspective in terms of how we are going to reallocate funds from SHF. I hope I answered your question. Sino ba nauna? Si Christy and then si Brian.
Hi, Doc. Good evening. Ay, dinig po ako. Hello?
Yes. I can hear you, Christy. Go ahead.
Oo, may Maropa, Doc, pero hindi tayo nag-abot. So, may Maropa din ako.
Hi,
Oo.
Christy.
Sa akin lang, Doc, hello. Meron po ba tayong sort of contingency mechanism pag po...
Sorry,
kasi po,
what?
diba, what
Sorry,
happened,
what? Anong mechanism?
So if there's a contingency mechanism, because right now, kasi po 'di ba, in an ideal setting by this time, dapat gumagana na yung ating special health fund na nandun yung budget ng ating mga LGU. Pero since nagkaroon nga po ng mga delay, magulo pa yung guidelines, etc., hindi pa po siya active. And yun nga po, bumaba po yung budget. And then, yung budget naman po sa DOH, inalis na rin po sa amin because of the devolution transition plan. So ngayon, we're caught in the middle because there's a need coming from, siyempre, our constituents who need to provide, but we cannot buy kasi nga po, we're bound by the devolution transition plan. And then, the LGUs cannot provide either because, yun nga, they do not have sufficient funds. So, ito pa is there, I don't know, contingency under mechanism by which we can access or ganun po ba? May iba pa po bang way to address the pooling of funds aside from perhaps, I do not know, engaging the private sector or yun na po kasi nga, ayun, there's a need, kumbaga parehas po, may gap po kasi, yun, kumbaga, hindi po kami makabili kasi we are no longer authorized to do so and we do not have the money to do so. Tapos hindi rin nabigay sa LGU yung pera kasi
Kamusta yung
din sa kanila.
Meron pa rin PhilHealth na bumababa?
Meron pa rin, Doc, pero mababa kasi eh. Like, for example, the Consulta package. Doon po sa TB program, example po, ngayon, yung mga multi-drug resistant patients, sa RH na sila magpapatingin. So, for example, yung monitoring po, they need to do a series po, di ba, ng laboratories. Yung Consulta po na binaba nila na 500 to 750 pesos,
hindi
when
enough.
we're at the fine print, it's a one-time access that was meant to augment the annual PE. So sabi namin, paano ngayon to? This is an example of one of the mechanisms that being said that will address the issue. Pero hindi, kasi one-time use, whereas our patients need regular monitoring. Mga ganun po. So, meron, pero may mga kailangan pa kong ayusin kasi kulang pa po.
Tapos mababa din yung revenues ng munisipyo from local taxes.
Yes. Okay. May mga iba na swerte na mataas like Puerto Princesa, pero 'di ba yung karamihan po sa atin hindi po ganun yung situation nila.
Oo. Wow. Kasi so ang intent, well, in terms of SHF, no, ang number one source talaga niya is should be PhilHealth. And that's what you're gonna hear from DOH. Um, and so yung hirap, no? Meron bang LEEs sa ano, sa Puerto Princesa, local economic enterprise na hospitals, Christy?
Ah, meron po tayong private hospitals, pero I think isa po ata yung ano, yung co-op na hospital, but
Oh, yeah, yeah.
sa ibang wala po, I think wala po masyado eh.
Oo eh. But then again, health system perspective, syempre out of pocket pa rin yung magda-drive doon,
Mm.
'di ba?
Yes. Ayun po, oo. Kasi nahihirapan lang kami address kasi yun po yung nangyayari ngayon. We're being asked na, o sino ngayon ang magbibigay ng gamot? Kasi sinasabi namin, devolved na po yan. Tapos ang sinasagot sabi ng LGU, hindi rin naman binigay sa amin yung pera.
Yeah.
Ano
Wow.
ba that? Pero sa amin po kasi yun yung ano namin ngayon. Kasi di ba totoo naman na bawas yung binigay sa kanila. So yun, medyo yun po yung ano namin ngayon, dilemma namin. Kasi, you know, merong may, may gap po ngayon na yun. We're trying to address.
Yeah, it's so hard to provide, advice on this because sanga-sanga yung problema eh. It's a problem that we
Siguro
ourselves created with, with
yes.
Danas and DTP, and then it never happened. Yeah.
Siguro talagang ano, parang we will just have to trust in the system muna and wait until everything is in place.
Hindi
Kasi yung inaayos,
yun
alam ko
Kasi,
inaayos pa nila yung HSF.
hindi rin, pero at the same time, gaano katagal maghihintay yung mga LGUs, right?
Yes. Opo.
Until we figure out how to run these things. So in other words, kailangan nang mag-pool na ng funds sa SHF and just, try to make it work. Para may proof of concept na tayo. Because honestly, LGUs are left on their own. They are now just looking at their own funding to they're just sorry. Yeah. So they are now just looking at their own resources and how they are going to finance all these things, 'di ba? Para yan yung isa sa fragmentation na na-create ng ng devolution. You created autonomous local health system who is now in charge of doing all the health financing functions of revenue pooling, revenue generation, pooling, and purchasing. But if they look at, let's say, other LGUs or nearby LGUs na baka naman meron siyang resources na wala ka that you can share, and baka meron resources si LGU that they can share sa other LGUs na wala sila. So, alam mo, it's not only financing that can be shared and pooled, but other resources as well. And that's where, innovation can come in. And that's and that's what you need to appreciate also sa integration, na hindi yung parang bayanihan, 'di ba? The concept of bayanihan. Parang LGU hindi ka nag-iisa. You have a neighboring town, and maybe a neighboring province who have the resources that you don't have, and maybe and maybe you can, share also the resources that you have na wala sila. So I think yun yung, while we're trying to figure out is these things on financing, because ultimately money will solve everything. Tama ba? Mas na meron na pera, mas madaling magpatayo ng ospital, mas madaling mag-hire ng doktor, mas madaling bumili ng gamot. Pero ngayon wala eh. So maybe we can start with mapping the resources that are available, and then we try to pull them together and learn how to share resources. I mean, that's what I can maybe advise Christy. You can start mapping the resource. Si Christy ba yun? Oo, tama. I guess yun yung my implementer hat.
Sige daw. Thank you.
Okay. Brian, yes? Go ahead, Brian. Is that an old hand?
Hello? Hello?
Yes, go ahead. We can
Opo.
hear you.
If I may share lang po yung universal healthcare implementation dito sa Quezon Province.
Oo.
Yung special health fund po ay mayroong provincial health board resolution kung ano yung allocation and utilization ng pooled funds. So, yung provincial health board, sila yung nag-decide kung ilang percentage yung para sa capital outlay, MOOE, and personal services. So ngayon, yung mga participating LGU, hindi naman mandatory na ibigay yung kanilang health budget dun sa pooled funds. So ngayon, yung mga commodities, health facilities, the province, the provincial government of Quezon, sila yung nagsasagawa nung sabak, nung pag-purchase ng mga commodities, etc. So centralized yung nagsasagawa nun. And yung mga LGUs naman, since hindi nga mandatory yung bigay nila ng health budget dun sa pooled funds, still may mga nagagamit sila sa local government unit when it comes to their operation in other health priorities ng local government unit. So yun po yung ginagawa ngayon dito sa Quezon Province as one of the integration site nung Universal Healthcare. Yun po, Doktora. Thank you po.
Yeah. Thank you, Brian, for sharing. Ano yan, di ba? Quezon, so si
Governor
Congressman
Tan po.
Angelina yeah.
Yes po.
Isa sa mga authors ng UHC law.
Yes po. So, ang isa rin po sa clamor, i-add ko na lang po. Doon naman sa national tax allotment or yung IRA po dati, kaya bumaba din siya ay dahil aside po nung mga budget officer nung nagmo-monitor ako ng TTP, ang basis kasi nung national tax allotment ay actual population. Dun sa IRA kasi is the projected population. So kaya since actual population ang ginamit na basis ng DBM or nung funding, yung nagfa-fund na national agency, maliit yung NTA ng mga LGU dahil nga po ang sabi nila actual population ang basis. So yun po isang factors bakit mababa din yung NTA. Thank you po.
Yeah. Thanks, Brian, for sharing. So, any other question? Maybe last one? Okay lang, May? Last one? Yep. Just in case na meron pa. Ang dami ko natutunan sa mga questions niya, and it's a humbling realization also na, you know, ang dami pa natin kailangan pag-usapan, um, from national and then yung local implementers and us from the development partners. Um, we've been supporting, DOH and PhilHealth in a lot of policy reforms sa ADB using the TA funds ng ADB. And we are very well aware with, all these things. But at the same time, hearing them from, PIDOHO, different implementation programs, ay parang, oo nga, prevailing pa rin yung glamour on guidance on SHF and then the integration. So, sana wag kayong mapagod ha. Kasi walang mangyayari kapag kayo yung susuko. Ayun. Meron na din po bang sign DPO? Ano yung DPO? Ano po mga tanong sa kompre? Nako, sino gagawa ng kompre? Ganun. Sorry, I put you on the spot, May. Oo, thank you HHRDB for inviting me, and thank you as well for asking those questions kahit na difficult, and sometimes nalagay ako on the spot kasi parang hindi yata ako dapat sumasagot na yun. But thank you, and I enjoyed listening to you. And I do hope we'll find, some, it's in the future, no, na we can work together. Looking forward to that. Sa health economics Saturday, I will not be doing the health economics. I was able to invite another speaker, si Dr. Michael Kaampued. So he will be lecturing some introductions on health economics May. So I will connect you with him. Thank you. Bye. Good evening. Good night.